Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi there, my name is Mike Sullivan and I'm one of the instructors with Valor Medical Services. In this video, we'll be discussing capnography. Now, as we begin this, we'll look at the core objectives as defined by the National Registry's 2016 edition for clinical core competency. We'll be discussing the difference between ventilation and oxygenation. We're going to learn to interpret blood oxygenation levels using both pulse oximetry and capnography. We'll discuss how end-tidal CO2 measures ventilation and perfusion. We'll confirm the phases of the end-tidal CO2 waveform of capnography, and we'll analyze the end-tidal CO2 reading, not only to determine and monitor proper endotracheal tube placement, but also to determine and monitor effective ventilation and to determine and monitor effective perfusion. Now, what is capnography? Well, simply, capnography is a way, or end-tidal CO2 monitoring, is a way to monitor the carbon dioxide that's coming out of the body each time we exhale. Now, carbon dioxide is a byproduct of the human metabolism at the cellular level. Every cell in our body, as it metabolizes oxygen and nutrients to make fuel, one of the things that results is carbon dioxide. It's one of the waste gases. Now, carbon dioxide is then picked up by the bloodstream, taken back to the lungs, where it's offloaded in the lungs, and we breathe it out. Now, there are various things that will affect the carbon dioxide level in our body. One is the metabolism. Think about an engine from a car. If the engine is running at a higher rate or higher RPMs, it's going to be giving off more exhaust fumes. We're the same way. If our metabolism is working harder, we're going to be giving off more exhaust fumes or more carbon dioxide. How well we're perfusing. If we're not perfusing very well, that means that the blood system won't be able to adequately get the carbon dioxide back out to the lungs, and it won't be able to off-gas it as well. So therefore, even if we have a lot of carbon dioxide in our system, we won't be picking it up and cleaning it out well. Another thing would be our respiratory gas exchange. If we're not able to exchange gases adequately at the alveolar level, let's say because of pulmonary edema or pneumonia or some other issue, say a pulmonary embolus, well, if we're not able to get that gas, that carbon dioxide, off of the red blood cells and into the lungs to be exhaled, again, we'll retain it in our body. The ventilatory rate. Think how much we have to get carbon dioxide out each time. If we're breathing 12 or 16 or 18 breaths a minute, we're taking out the carbon dioxide at a good level. But if for some reason the patient's ventilatory rate drops to 6 or 8, say because they're extremely hypoxic or because they've possibly overdosed on, say, opioids or something similar to that, or they're having some other ventilatory rate issue, they'll retain carbon dioxide. On the other side of that coin, if they're hyperventilating and they're off-gassing too fast and exhaling too quickly, that will cause their carbon dioxide levels to be too low. Lastly, medication administrations. And the one big one we can think of off the top of our head is sodium bicarbonate. Now, sodium bicarbonate is administered as a buffer. It's done to basically convert positive hydrogen ions into water and CO2 gas. So, if we administer sodium bicarb to a patient who is potentially acidotic, it will result in excess carbon dioxide being off-gassed. Now, when we monitor carbon dioxide, there's different ways of doing it. We typically monitor what we call the end-tidal CO2, which is at the end of the patient's respiratory cycle, near the patient's mouth, or in the case of an intubated patient, at the tip of the ET tube. It's measured many times in millimeters of mercury, or a percentage of the exhaled volume. Now, we can monitor carbon dioxide with various different methods and different formats, and we'll talk about some of those. So one of the methods is qualitative. We can also have quantitative, and we can also even get a graphic representation of this. Now, when we talk about qualitative measuring, look at the beginning of it where it says qualitative. What are we getting? A quality. It basically is giving us a true-false reading. It provides a rapid yes-no result as to is there a bunch of carbon dioxide or is there not. Now you can see in the picture there an easy end-tidal CO2 meter. Typically that can be hooked up between the bag valve mask and the ET tube, and what happens as the patient exhales, we look for a color change on the paper in there to determine if there's any carbon dioxide or if there's a good amount of carbon dioxide in there. Well, that's all well and wonderful, and it is a very inexpensive, simple-to-use system. It doesn't require any calibration, and we can actually have more than one on every apparatus because they are so inexpensive. I've known at some points agencies may have one near the bag valve mask, they may keep another one in their intubation kit, and they may keep another one handy from the airway kit that goes in the house. Well, that's great, but it's very limited information. Also, it's limited use. It won't work for a long duration of time, and it doesn't really give us a lot of information. It tells us in the beginning that yes, there's carbon dioxide there, but once it's been used for a little bit, usually about under a minute or so, it's not going to be long-term reliability. Lastly, it can be easily damaged or contaminated. You've got a patient who's intubated. They start vomiting. Well, if vomit comes up the tube, possibly they were not intubated in the right location. Maybe that's why we're using this to check. We've got a missed intubation, but if vomit gets up and gets on that paper, it's no good. Now, the nice thing is you can have an extra one, so you take this one, throw it away, and grab another one. On the other side of the coin, if we're looking for long-term monitoring of an airway placement from the scene to the truck, all the way to the hospital and to the bedside when we get to the ER, you're going to have to go through several of these. So what else can we come up with? Well, quantitative measurement. Now, quantitative, unlike qualitative, quantitative gives us a quantity or an amount, a numerical reading. It doesn't just tell us that, yes, CO2 is present, isn't that nice? It tells us about how much CO2 is present. Now, these devices here are fairly inexpensive, again, when you look at the big scope of things. The one on top is attached between the bag valve mask and the ET tube. The 39 gives us an ETCO2 reading or a carbon dioxide reading, and on the bottom it tells us the patient's breathing 13 times a minute. Whether we're assisting it, whether we're bagging, we don't know, but it lets us know, okay, here's the respiratory rate and here's the CO2 level. Now that could be good all the way to the hospital, unless again they become contaminated or something happens or it becomes damaged. But barring that, we could use that all the way from the scene to the bedside in the ER. Bad sides of these, there's no waveform. We have a number, and that's great, but if the number starts to change, do we really know why? We look at the one underneath it, that's attached into a pulse oximeter, where again, we have the blue probe there that goes on the patient's finger to measure the oxygen saturation level, and on the blue wire to the right of the machine, we have a little spacer that goes in between the bag and the ET tube, and the readout will give us, again, the numerical series like we have on the one up top. Now those there are a little bit more durable than the one up on top, but again, there's no waveform, and they only really work on intubated patients. We've got to sort of have a tube there to connect the tube connection to. Now, the most advanced version of it is what we call quantitative with a waveform. Now, this provides us not only the numerical result that we see here, the 41, as far as what the carbon dioxide level is, but it can also be used many times in breathing patients. And this waveform can be an excellent assessment toolbox in our assessment. Now, these are easily recorded, they're documented, and it's very easy for us to monitor. Now, these are definitely the most expensive of all the options. Many times they're going to require calibration, and some versions can be damaged pretty easily. Now, typically these may be installed as a feature or a module in your standard cardiac monitor, in which case they usually work based on one of two principles. The two common configurations we see are mainstream or side stream. Now, the picture here shows what we call a mainstream adapter. The adapter up in the top center of the picture is attached between the tube and the bag valve mask. That probe snaps onto the side of it there and actually reads across the adapter to determine the amount of carbon dioxide. Now, this is monitoring right at the end tidal section at the end of the ET tube and works very well. They don't require as much calibration as some other units, and again, works, very well, gives us not only the waveform, but the numerical, and the other end is plugged into the monitor where it will feed it and record it along with the rest of our EKG information and anything else we have. So now this configuration is a great one. However, there is a couple of little downsides to it. One of the big downsides that I've seen in the field is that end-tidal CO2 sensor right there that attaches to the tube connects to the monitor by that cable you can see. If that sensor or the cable it's attached to becomes damaged in the field, especially in a very unpredictable pre-hospital environment, let's say somebody gets a little bit over-aggressive with the shears trying to cut clothes off a trauma patient, or possibly the patient becomes combative and is yanking at things and damages the cable or the connection, or something else happens, maybe it gets left on the ground, accidentally stepped on because no one notices it, that is an extremely expensive piece of equipment. So, what could we do to have our sensor a little bit more protected and a little bit safer? Also, another limitation we have on this is it's only for intubated patients, so it kind of limits what we can use it for. Let's look at another configuration. This is the side stream configuration. Now, in the side stream configuration, this connects to the cardiac monitor. You'll notice the connection is very similar to the one before. And in that low flow case, which is very well protected and hardened, there's actually a pump. And that pump draws in a small amount of air from the ET tube or from a connection and actually allows it to be analyzed in that protected case, so it's much less vulnerable, much less likely to be damaged. Another nice feature about it is we can hook up various devices to it. Here's an example of two different choices, and as you can see, the one on the left would hook up to the ET tube, and the pump would pump the air back through that connection, the white connection there, into the side stream monitor. However, on the right, we see a nasal cannula. Now, one side of that would hook to the oxygen. That would be right here would hook to the oxygen itself, and this item here would actually hook to the end-tidal CO2 monitor or that low-flow pump. Now, this will actually pull the patient's exhaust air or patient's exhalation back to the monitor and actually allow it to be read again by that pump. So we've got different devices, and the side stream can give us a lot more options. This one typically is one of the easier ones to use. One thing to remember, most side streams require calibration. However, the fact that we can use it with both breathing or intubated and non-intubated patients is a big plus for us. So now let's look at why we monitor CO2 or end-tidal CO2. For many years, end-tidal CO2 monitoring has been a mainstay of hospital-based anesthesiology and procedural sedation, as it provides many benefits over just O2 saturation monitoring. This vital sign will more adequately monitor the patient's airway status. This will indicate a tube displacement, typically within seconds. It will indicate under or over bagging much more effectively. It will indicate if we have a tube problem or a vent circuit failure more quickly. All of these because if we're just monitoring the patient's O2 saturation, let's say at the pinky or at the index finger, we won't see a change in the patient's O2 levels until their finger actually becomes hypoxic. How much have we been not oxygenating the brain by that point? This will actually let us know by a change in the tube status much earlier. Additionally, end-tidal CO2 monitoring can provide us more information about the patient's overall respiratory status and what's going on. So, another nice thing about end-tidal CO2 monitoring is it's much less sensitive and less affected by motion artifact. It's less affected by poor perfusion. For example, if you have a patient with peripheral vascular disease or possibly clear nail polish on their fingers or acrylic nails, we can have trouble getting a good O2 saturation reading. It's less affected by dysrhythmias. If the patient's rhythm changes dramatically, even if they're not perfusing their pinkies, we'll still be able to tell how well gas is exchanging in and out of their lungs. It's less affected by fluorescent lighting. You may not know this, but fluorescent lights can cause some issues with SpO2 monitors. Another issue is it's less affected by red cell disturbances. Let's say the patient has anemia. They have a very low red cell count to begin with. So although their red cell count is low, their SpO2 can look at 100%, but they're still not getting enough oxygen to their bloodstream peripherally. They're not perfusing well, not because the red blood cells are not saturated with O2. 100% of the blood cells are saturated. The problem is, there's not enough blood cells to begin with. Now when we get into carbon monoxide poisoning, most providers know O2 saturation tells us what percentage of the red blood cells have something attached to them. We like to assume it's oxygen, and in most cases it is. But if a patient's had an extensive exposure to carbon monoxide, the red blood cells can be saturated by something else. So a patient can have 100% O2 saturation, but if they're all saturated with carbon monoxide, it's not telling us a lot about what's going on with the patient's perfusion status. So O2 sat, while a wonderful tool and something that we use in the field very effectively, has limitations. Many of these limitations can be overcome by also having end-tidal CO2 as a monitor. So, if we're going to monitor it, what's normal for it? Well, the normal PaCO2, which would be based on taking an arterial blood gas, is between 35 and 45 millimeters of mercury. Now, we don't do arterial blood gases in the field, at least most providers don't. However, what we do is we can determine this based on what we're getting at the exhaled level. If they do a mixed venous blood gas, again, this would be how much CO2 is in the venous system. That would be about 41 to 51. Now, the arterial levels and the mixed venous blood gas levels, again, we'll seldom see them in the field. We may see them on lab slips, or if we're doing interfacility or some critical care air medical transports. The one we're most likely to see is the one on the bottom, the exhaled carbon dioxide, which is what we monitor with end-tidal CO2. This is 35 to 45, or I've seen 33 to 43, depending which book you read, but again, somewhere in that general variety. In some monitors, they may actually display it as a volume, which should be 5% volume of what's being exhaled, should be carbon dioxide. Okay, so now, earlier I stated this is a great way to monitor the patient's overall perfusion status. But what is perfusion? Well, perfusion is actually the delivery of oxygen and nutrients to all the cells and organs throughout the body, and it involves the removal of the waste products, especially carbon dioxide. If we look at perfusion overall, it's a product of circulation plus ventilation plus diffusion. All of these come together, and they all have to be good in order for adequate perfusion to occur. So what is circulation? Well, circulation is the flow of the blood from the heart throughout the body, eventually returning back to the heart. If we have blood loss, or say a pulmonary embolism or some other type of embolism, if we have cardiac arrest with poor perfusion, or severe cardiac dysrhythmia, any of these would result in a compromise of circulation. If we're not adequately circulating blood to go out to all the cells and pick up that carbon dioxide, we're not going to be getting it out of the body effectively. This waste product, or what we call a trash gas, can actually build up in the peripheral circulation and cause problems. So good circulation means we're going to be dropping all the carbon dioxide back off at the lungs and making sure it gets out of the body. The next factor in our equation is ventilation. Now, ventilation actually represents the actual physical movement of air into and out of the lungs. So we have to be moving an adequate tidal volume in and out of the lungs in each breath and overall in each minute to have good ventilation. If a patient has asthma, COPD, edema of the airway or swelling, a foreign body obstruction, these can all cause a blockage that would limit the perfusion. It would limit ventilation. Also, if a patient, say, had a stroke or a head injury or possibly an overdose, if they're unable to ventilate adequately, they can't get enough tidal volume or enough rate, we're not going to have good ventilation. Lastly, we need to have good diffusion. Now, diffusion is where the transfer of oxygen onto the red blood cells in the lungs and the offloading of CO2 from the red blood cells at the alveolar level takes place. If a patient has pulmonary edema or damage to the alveoli from smoking or chemicals, possibly CO poisoning, smoke inhalation, anything that's blocking part of the alveoli, that would all cause a diffusion problem. Any of these not working properly would not only compromise perfusion, but would compromise the ability to off-gas the CO2. So now let's look at the displays and start figuring out what they all mean. We're looking at the waveform here, and if you look from section A, that is where the waveform actually begins. And as we're looking at the waveform itself, we can tell that it starts at a baseline. It starts at the baseline there because that is where the patient is not exhaling anything. So if they're not exhaling anything, we know that they've got no CO2 coming out. Now, as the patient begins to first exhale, the gas that's going to be coming out initially will still be down here at the baseline. The reason for that is the patient is exhaling gas that's in their upper airway, their oropharynx, the nasopharynx. It hasn't made it to the lungs, so there's no CO2 in it. As the upstroke begins here, it's because little by little, the air that's coming out is coming from the lungs, and it's full of CO2, or at least enough to make it all the way up to B here. When it gets up to level B, that's where we're at full exhalation, and it rides across this plateau for a while until the patient starts to inhale again. As the patient inhales, the machine's going to see fresh air coming by it. Or if we're bagging, we make the patient inhale by enforcing positive pressure. It's going to be pushing fresh air by it. Either way, there'll be a sharp drop-off from C down to D as the patient's exhalation ends and inhalation goes through. By the time it makes it down to D, they're at full inhalation level and they've gone all the way through. Looking at the waveform a different way, we know that the normal baseline at A and D should be calibrated where it comes up at about a 0 on the scale. The max height of CO2 should be up here at C. That's where we've gotten to full exhalation or the highest possible concentration. The horizontal distance from A to D, from starting here, at this point I'm going to mark there, and over to here is the time of one respiratory cycle. So here they've started to exhale, they get all the way out, they've exhaled, they're at maximum, they start to inhale, this drops off, and they're at full inhalation here, and lo and behold, they'll start to exhale again. Now this can tell us a lot, not only about how the patient's breathing, but what their level is. So it gives us not only the number, but a graphic representation of how well they're breathing. Let's look at another waveform here, broken down. In phase 1, we call it the respiratory baseline. There's no CO2 present. The air is coming, like I said, from the dead space. As we get from phase 1 into phase 2, we begin seeing the ascending phase. The air from the dead space begins to mix with the air from the lungs to reach up to that peak level there. The more and more air coming from the lungs, the higher the reading will be, till it reaches up into here at B. Now once we reach phase 3, or the expiratory plateau, this is, again, pretty much a uniform concentration, maybe increasing just a little bit, but the wave reaches the plateau and peaks out here. As the patient goes from phase 3, the expiratory plateau, into phase 4, it suddenly drops off. This is our inspiratory downstroke. So instead of looking at this is the patient taking a breath, when the patient's breathing in, this goes down. When the patient's breathing out, the waist goes up, or the CO2 level goes up. That would let you know, again, how the patient's breathing. Now, if, for example, there were a whole bunch of these, but they were all very little, that might tell you the patient's breathing very fast. And if they're very little, say they only come up to here, that would let me know that, well, there's not much CO2 coming out with each breath because maybe the patient's not breathing effectively. Maybe there's a problem, or maybe they've blown off too much of their end-tidal CO2. So what can we use end-tidal CO2 to tell us about the patient? Well, let's look first at an intubated patient. Number one, we can use it to verify ET tube placement, not only initially, but continuously. As I said earlier, one of the great things about this is we can hook it up very quickly on the scene, and we're monitoring the end-tidal CO2 from the time we've placed the tube all the way to the bedside at the hospital. If we know what the value is when we place the tube and it's continuous, any sudden drop in the CO2 level is a red flag to us that possibly the tube has become displaced, or maybe the cuff is damaged, or maybe it's obstructed by something. Now, one more thing to think of, and it's not mentioned here directly, but many services now use some form of transport ventilator. Now, when I got into EMS a million years ago, back in the land of the dinosaurs, we would always bag our patient, and we could always tell if we were beginning to have a change in the patient's lung compliance, their chest wall compliance, if it became suddenly harder or suddenly much easier to bag the patient. But if you're using a transport ventilator, you're not going to be able to get that immediate feedback. Think about it. If you suddenly have a drastic change in your end-tidal CO2 level, it could not only indicate an equipment failure of your ventilator or your vent circuit, perhaps something has become dislodged, something has become broken, a vent circuit has become damaged or crimped. So again, it gives you another great way to monitor not only your equipment, but to make sure the ventilation that you're providing for the patient is the best it can possibly be. Now on the bottom there, we can also use end-tidal CO2 to assess the effectiveness of our chest compressions. If we have a cardiac arrest patient we're doing compressions on, high-quality CPR should maintain end-tidal CO2 levels, as peripheral perfusion is a key factor. So the better we're perfusing, the better our end-tidal CO2 will be, which is a result of good chest compressions. What else can it tell us? Well, end-tidal CO2 can be the earliest indicator of a return of spontaneous circulation. A sudden dramatic increase in the end-tidal CO2 levels can be an indication that the heart's begun pumping on its own. Thus, we've had a return of circulation. When the heart begins pumping on its own, it will begin to wash out any excess CO2 that accumulated in the cells. No matter how good our CPR is, it's never going to be as good as the heart functioning on its own. So let's take, for example, we have a cardiac arrest. We start off with an initial end-tidal CO2 of 15 to 20. We get to the point we're doing great CPR, high-quality CPR, limiting hands-off time, good compression depth, good recovery, and we get it up to 20 to 25. Well, that's great, and we know we're doing good CPR. However, it suddenly jumps from 25 up to 50 or 55. Why would it jump up so high? Well, as we know, even the best CPR is not going to be as effective as the heart pumping on its own. So what's happening now is any excess CO2 that accumulated in the distal periphery is going to begin getting washed out. It's getting picked up because circulation has gotten dramatically better. That massive improvement in circulation is going to mean that it's taking out a bunch more CO2, so now it's going to be high. Now that 50 to 55 is going to rapidly work down as we go ahead and continue bagging the patient. Lastly, this can be an excellent indicator of the probability of successful resuscitation. Now we all know that we should be treating the patient, not the machine. However, an initial end-tidal CO2 level of over 10 indicate a much higher probability of a successful resuscitation outcome. The converse of that is, if you have an initial end-tidal CO2 level of 0 to 5, you know that the patient has been down for an extended period of time and many of the cells have stopped functioning. Why? Because we're not seeing any exhaust gas from any of these cells. If these cells have stopped functioning, well, we have a much less chance that we're going to have a good outcome. So this can give us an idea, again, what our probability of a successful resuscitation is. Lastly, it can allow providers to adapt the ventilatory rates and volumes to maximize perfusion. Providers can monitor the end-tidal CO2 readings to determine the need to either increase or decrease the rate of ventilations given. If you're bagging a patient and the rate is way too high, we need to increase the BVM rate and volume. Why? Well, we need to take out more effectively. If the readings are way too low, we may need to decrease the BVM rate or volume. Why? Because we're getting too much end-tidal CO2 out. So this can give us a lot of information as far as what's going on and let us make sure that we're not only ventilating the patient, but doing it at a rate appropriate to maintain the best possible outcomes. This can be very handy if you have a provider who's been bagging for a long period of time and you notice the readings start to creep up. Well, perhaps he or she is getting tired. Perhaps they're getting that hands cramping, wrists cramping. Or on the other side of that coin, if the readings are getting very, very low, perhaps they're very excited. We all know it can be a charged situation in the back of a truck or working a resuscitation. All of a sudden we notice that instead of bagging a nice 10 to 15 times a minute, they're bagging somewhere around 30 times a minute. Well, the readings are too low, so we can tell them to adjust their bagging. This is all things we can tell that we never would have gotten without end-tidal CO2 monitoring. Now, how about non-intubated patients? Because like we said, with the side stream systems, we can actually use this on non-intubated patients. So let's look at the first film here. This shows us what we call an asthma with a shark fin wave. Now this patient would be an asthma attack typically. We see how they're having a lot of struggle getting their respiratory rate up. They're also clearly retaining CO2 because their level is very high. So they're having trouble getting CO2 out. They're retaining excess in their body. The shark fin wave is a textbook presentation for asthma. So we see this, maybe the patient's wheezing or maybe they're not wheezing. It's possible they're having an asthma attack that's so bad they're not moving enough air to actually make them wheeze. So we're watching their CO2 level go up. We're seeing these ugly shark fins swirling around the patient, and we know we need to do something, whether it's a neb treatment or some other type of bronchodilator, and that way we can assist their ventilatory motion and decrease their CO2 level. With the patient on the bottom here, they're clearly hyperventilating. Look at the number of respiratory cycles that are going in and out. That's a very high number. There's a lot of waveforms in there. On the other side of that coin, their waveforms are getting lower and lower. They're down at a CO2 level of 30. Pretty soon they're going to be telling us that their fingertips are starting to tingle or their nose is starting to tingle. Why? Because normal is 35 to 45, and the more CO2 they blow off, the better chance that we have a low level and begin showing signs and symptoms of it. It's extremely important with the patient on the bottom that we realize they are off-gassing so much CO2, we need to work on controlling their breathing. That gives us not only their respiratory rate very quickly in a very graphic display, but it lets us know that, hey, maybe we can get them from 30 to 35 by controlling the breathing a little bit. Maybe we can get the monitor where they can see it, and we tell them try to coach their breathing to get that number up. Little by little, again, all things that we're getting from a CO2 monitor. Some other things it can tell us about non-intubated patients. It can gauge their response to treatments. Again, a bronchodilator or a nebulizer treatment that we give to that asthmatic patient. If their CO2 level starts working its way down, we know they're breathing better. If they're having CHF exacerbation, how well are they responding to that? How about a patient with sedation or analgesia of some type applied? Whether it be opioids, whether it be ketamine or anything else, we know that we want to monitor their breathing, and this will not only help us monitor their breathing rate, but also if we see the level getting high, we may need to do something to coach their respirations. When you have a stroke or a head injury patient, in many cases, a head injury patient, you want to monitor their CO2 to make sure cerebral perfusion is good. This can also tell us about that. It will help us monitor perfusion status. Quite frankly, as we look through overall with end-tidal CO2, just its ability to monitor tubes for intubation and confirm tube placement and help us monitor for return of circulation are wonderful. But adding to this is one of the greatest developments and advancements that we've seen in pre-hospital care for the past several years. It's already proven itself invaluable for intubated patients, transport situations, especially with providers being busy in the back of the truck. You can get a very quick snapshot just by looking at the monitor. Looking forward, it can also prove itself as a major asset for other purposes, other aspects of patient treatment. Again, the asthma patient was a perfect example of that, or a hyperventilation patient. Are they hyperventilating because they're hyperventilating, or is it because they're having a pulmonary embolus? Well, with this, we can actually tell that they're not retaining CO2, they're actually blowing it off too fast, and it lets us know. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.